Hello, everyone. I'm often asked to speak about this subject. It is one of the areas that is, I guess, one of my specialisms that I've developed over the years, and that's, hormonal solutions to aging. And in a way, the context of hormones is often different because patients tend to seek hormonal help when they're symptomatic. So classically, it's your menopausal woman who has quite a precipitous drop in hormones, is symptomatic. That affects 80% of women who go into menopause. So they come for symptom relief and seek hormones as a solution. However, there isn't this other side to hormones that it's useful to be aware of, and that is the anti-aging or the better aging effects, I prefer that term, of the hormones. So I want to walk you through that and what my experience of that is, and of course, how to achieve that safely. So I'm going to try and cover this subject in, well, if I can, in about 30 minutes. And it'll really be a whistle stop through some of the established benefits of the hormones, and I just want to share those with you. So this first slide really looks at what are the things that we feel contribute to aging in the first case. And you see there's a list there on the left: inflammation, oxidative stress, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, epigenetic alterations, and genomic instability. And at the bottom, I quite like that graphic, which shows you that normal aging, i.e. normal aging in our society today, is associated with age-related disease as we progress in age. Although optimal longevity really should be living a healthy life, dying of old age, but without a disease process. So the definition of aging in my book has to include the propensity to have illness as we get older, and how can we offset that? What can we do about that? Today, there are other things. Obviously, today my focus is on hormones. This also highlights one of the things that wasn't in that list of contributing factors to aging, and that's the neuroendocrine theory. So that's where we're at today. We're going to focus on the hormonal aspects of aging. So here's one of the challenges that we encounter with aging as scientists, as practitioners, doctors, and that is, how do we detect it? It's very difficult to measure. If we're talking here in this slide about brain degeneration and mild cognitive impairment, which is MCI, how do we differentiate that from, where the heck did I put my keys this morning? We all have lapses of memory. When does that become significant? It's difficult to define, it's difficult to measure, and that's one of the challenges of measuring early disease changes, is what are the markers that we need to use that would really indicate clearly that we're running into trouble. It's not easy. Here I've used the example of detecting the emergence of a breast cancer, and this is the other side of the work that I'm involved in. Do a lot of breast health work, a lot of breast cancer prevention. One of the challenges there is really, even with mammography, we're detecting lumps which are 1 centimeter in size. By the time they get to that size, they represent 500 million cancer cells. You can sometimes pick them up a little bit smaller than that. But the challenge with that is that, you see, once they reach that size, we know this from wide excision biopsy, in 4 centimeters of tissue, there are microfocal deposits in 2/3 of cases where we thought there was a single tumor. So we can't reasonably argue that mammography is early detection. This is another example of the challenges that we face. Early detection is one of the areas of special interest in my work, in my clinical work, is how can we detect things early in order to react to that and do something about it before these things become more clinically significant. So, and that's why since 2004, 2005, I've been offering breast thermography in my clinic. Why? Because I believe that detecting heat patterns gives us an earlier gives us an earlier sign that a breast is running into trouble. So this we do, and we've been doing it from 2005. Early detection, we think as early as 6 to 10 years before something becomes visible on a mammogram. So this is something, if you don't know about it, do check it out. There's information on our website about this. So let's move on to hormones. And I want to, as I say, really run through the key things with you on this. Those of you who have seen the film Sex and the City 2 will be aware that the Samantha on the far left, the scene where she forgets her bioidentical hormones, or not forgets, sorry, they're confiscated from her on her trip. And there's this rather amusing scene where she's eating tubs of hummus to try and get phytonutrients to replace her estrogen. So it's where there's a mention of bioidentical hormones there. And of course, earlier than that, Suzanne Summers really created a lot of buzz around the notion of hormonal health and replacement with bioidentical hormones rather than synthetic hormones. And she did raise the flag over BHRT. Let's look at andropause and menopause and look at the similarities. I'm not going to talk about men's health in this talk. It's primarily focused on women's health. But I want you to look at these similarities. What happens in men, what happens in women as hormones fall. So testosterone is the main hormone in men, estrogen in women. I would argue estrogen and progesterone are equally important. But look what happens. Increase in body fat, both sides. Reduction in well-being, sexual function diminishes, but look at the disease process. Increased risk of heart disease, increased risk of osteoporosis. In men, increased prostate cancer, and in women, increased breast cancer. So there are similarities in the physiological and pathological changes that can occur as hormones fall. So that might give us a clue that maybe hormones contribute not just to reduction in function, but into propensity to disease as well. So these are some of the things that, some of the symptoms associated with menopause. It's not a pretty reading list, I'm afraid, but hot flushes, vaginal dryness, irritability, anxiety, depression, insomnia, fatigue, aches and pains, incontinence, poor short-term memory, brain fog, women will commonly say Alzheimer's disease, osteoporosis, spine and hip fractures, loss of teeth, wrinkles, dry skin, cardiovascular disease, and of course, cancer. So, these are serious changes. It's not pretty, is it? But these are commonly associated with hormonal decline in women. If you look at a graphic of how the hormones change over time, it's interesting to note that they don't all drop at the same time. For example, DHEA, which is really a parental hormone, we'll come on to that later, that tends to fall really from when you get into the 30s. And then estrogen, progesterone will fall later. Progesterone tends to fall before estrogen. So often as you become perimenopausal, not uncommon to have an estrogen dominance because of lack of progesterone. And that's very common to see in clinical practice. So if you look at the decline in testosterone, of course it declines in men, everybody knows that with age, but look at the decline in women as well. Testosterone, very often overlooked when we're addressing hormones in women, when we talk about HRT, very often does not include testosterone, but it should, because women also have a decline in testosterone as well as estrogen and progesterone. We'll come back to that again a bit later on. Estrogen and fat. There's some misunderstanding about this because everyone believes estrogen makes you fat, but it's quite the contrary. So estrogen and progesterone play vital health maintaining functions in non-reproductive tissue like heart, bone, and brain. Body shape change after menopause is likely to be linked, at least to some degree, to estrogen deficiency. Estrogen deficiency is associated with increased plasma-free cortisol levels, which may contribute to the development of visceral obesity during pregnancy. Estrogen therapy has been shown to decrease free cortisol towards the level found in premenopausal women, suggesting a role for estrogen in protection against postmenopausal accumulation of visceral fat. So quite the opposite of what people generally think. Of course, we're not referring to oral estrogen here. It is better we'll talk about this in a minute, Better to give it transdermally. You get less fat accumulation that way. It's much better to administer it that way. So here we see that sexual problems are associated with low estrogen, particularly as it relates to dryness and pain on intercourse. That's very related to estrogen levels, is what this slide shows. If you look at Alzheimer's disease, definitely an association, so that when estrogen levels are higher, when they're restored by treatment, there is a significant reduction in the incidence of brain degeneration, Alzheimer's disease. Energy and fatigue also associated with estrogens, because one of estrogen actions is that they're dopaminergic, that increase blood flow in the brain. And not just estrogen, I hasten to add, progesterone also improves brain function and synaptic function. So does testosterone. So it's almost like this synergy of hormones can improve brain function. Here we see depression is relieved significantly by transdermal estrogen. Now, it's very common in practice, in general practice, for women who are of menopausal age to be given antidepressant medication, when in fact, I believe it would be better if they had their hormones restored. So if they had the estrogen and progesterone given back, preferably in natural form, this would significantly allay some of the depression that's going on, and that is related to decline in hormones. I don't think these women should be given antidepressants. They should have their hormones restored properly. Here we see transdermal estrogen increasing bone mineral density. Remember what I was saying earlier about the tissue restorative effect of estrogen or with hormones generally. Over and above symptom relief, these are real tissue, brain, bone benefits of replacing hormones. Again, emphasis should be in bioidentical, body-identical form. Here, this slide shows you how estrogen is able to increase bone density, but so are androgens, and so DHEA as well. And these are three classes of hormones that are commonly used in properly replaced hormones. Let me put it that way. So what do we achieve from estrogen restoration? Well, controls hot flushes, so symptom control, maintains pelvic health, improves cognitive function, improves mood, restores sleep, maintains thickness and fullness of skin and hair, very often overlook that one, protects against colon cancer, protects against macular degeneration, prevents atherosclerosis, protects against hypertension, improves insulin sensitivity, prevents osteoporosis, osteoarthritis, and improves memory. All desirable benefits from correctly restored estrogen. A little bit about estrogen receptors, because I know this will be familiar to some of you, but there are basically two main estrogen receptors, estrogen receptor alpha and beta. Generally thought that if you stimulate the alpha receptor, it leads to breast cell proliferation, whereas the beta receptor stimulation of that inhibits proliferation. And that really that it is a good idea to be stimulating alpha and beta. Estradiol, one of the three main hormones, tends to stimulate alpha and beta to the same degree. Estriol, which is a weaker estrogen, tends to stimulate the beta receptor and has a modulating effect on the actions of estradiol, which is why those of us who prescribe bioidentical estrogen will often use a combination of estriol with estradiol in order to have that more healthy modulated effect of estradiol at the alpha beta receptor. And the other thing to note on this slide, that conjugated equine estrogens, so derived from horses, they downregulate the beta receptor. That's not a good thing. If you're downregulating the protective modulator receptor, then that's not a good thing. You'll be familiar with this pathway, that is the breakdown or metabolism of estrogen, the 2-hydroxy pathway, 16,4-hydroxy. We generally believe, based on the data, that if you can encourage the 2-hydroxy pathway, that's safer. Those estrogens are excreted without any ill effect. Whereas the 16 and 4-hydroxy tend to be more toxic to breast tissue. We don't want those. There are ways of changing these epigenetic pathways, usually by things like indole-3-carbinol, diindole-methane, or DIM. What they do is they encourage estrogen down the 2-hydroxy pathway. So what does that translate to? It translates to protection of estrogen-sensitive tissues like breast, uterus in the longer term. And of course, this is very relevant to a discussion on breast health and what you can do to protect breasts. This is one of the things that should be addressed. In terms of receptors, this is also important because there's a lot of talk about estrogen receptors being everywhere, but then progesterone receptors are everywhere. And I just want to underline that there are progesterone receptors in the brain, in the uterus, which we know, of course, in the breast. And those tissues need to see progesterone as well as estrogen. So when women who have had a hysterectomy are and still are told that they don't need to have progesterone, that to me is not good science, because what about all of these progesterone receptors which are elsewhere in the breast, for example, protecting against the stimulatory effect of estrogen? Those receptors still need to see progesterone. So in my book, women should never, there's never a case for giving a woman estrogen without progesterone. That's the take home from that slide. If you look at, or if we look at the progression of incidence of breast cancer, obviously there's an age-related increase in incidence, but it's also interesting that this seems to correlate with the fall off of progesterone levels. So, which also occurs as a woman ages towards perimenopause, menopause. If you look at this slide, what we tend to find in a normal menstruating woman is that progesterone and estrogen are balanced. So in this slide, the progesterone is red, the blue is estrogen. And then as you get into sort of perimenopause or anovulatory premenopause, then what you tend to find is that estrogen dominates, progesterone falls off. That's classic. Progesterone always falls before estrogen does. And then as you go into menopause in this C columns, then you can see estrogen is still produced more than progesterone. So you can still have a relative estrogen dominance even in menopause. So what does progesterone do? Let's focus on that a little bit. So progesterone balances the actions of estrogen. It promotes thermogenesis, acts as a natural diuretic, aids thyroid hormone action, helps stabilize blood sugar, normalizes zinc and copper ratios, and promotes proper cell oxygen levels. So there's quite a few things that progesterone does. On the left is a woman without progesterone, and on the right is a woman with progesterone. And so the main point here is that progesterone is definitely the brain calming hormone for women. And this can be quite dramatic. You have women presenting with disturbed sleep, anxiety, and commonly that's due to low progesterone. Once they have the progesterone back, it's transformative. They move from the woman on the left to the woman on the right, very often in 90+% of cases. Here, this slide shows the progestin theater. And it's important to note that not all progesterones are created equal. So the synthetic progesterones should really not be called progesterone, because what you see there in blue is these synthetic progesterones often have androgenic, estrogenic, glucocorticoid, as well as progestational effect. So when I talk about progesterone, I'm talking about natural micronized progesterone, not progestins. Now, these are often conflated by doctors when we talk about progesterone, or they often refer to all of these together and lump natural progesterone with progestin. That is not the case. It should not be the case. They have completely different effects. And that's the point from this slide. And here I illustrate that more. So here we compare natural progesterone on the left against one of the synthetic progesterones, Provera or medroxyprogesterone, and look at the difference. They're almost opposite effects. So progesterone maintains pregnancy, whereas the synthetic causes birth defects. Progesterone improves mood, but synthetics can cause depression, improves sleep against insomnia and irritability. Natural progesterone diuretic, fluid retention with medroxyprogesterone. No effect on blood sugar, but medroxyprogesterone raises blood sugar, improves lipid profile, worsens lipid profile. No evidence of increased cardiovascular disease with progesterone, but can cause heart disease with the synthetic. Reduces estrogenic stimulation of the breast, increases estrogenic stimulation of the breasts. That's important to note that, because we'll come on to that and the context of this in the incidence of breast cancer in a minute. So progesterone is very much a protector of the breast and prevents breast cancer, but synthetic progesterone, particularly when they're combined with estrogen, can actually cause breast cancer, and that is one of the problems. So this, I think, is still one of the pivotal papers by Kent Holtorf. I think it was 2008, I think my memory serves me correctly there. It's a very good review of the difference between bioidentical or body-identical hormones, the difference in effect that they have on the body generally, compared to standard HRT. Now, here's an important paper that was published as long ago as 2005 in International Journal of Cancer. It's very important because we've actually known quite a long time that the combination of estrogen with the form of progesterone influences the risk of breast cancer. So what this study shows, and it was on nearly 70,000 women, is that here you have estrogen alone. Does it increase risk of breast cancer? It does, marginally. But when you combine estrogen with different forms of synthetic progesterones, i.e. progestins, you see an escalation in the risk of breast cancer. When you combine estradiol with natural micronized progesterone, guess what? We don't see any increase in the risk of breast cancer. So we should have known from 2005 that the way to administer hormones to women, replacement hormones, should be to use estradiol in combination with natural micronized progesterone. That is starting to happen in general practice now, more than it was, but it's taken a long time to get to that. And in fact, synthetic HRT is still used. And when you look at this slide, we have to raise the question, well, why is that? And it shouldn't be. If you look at the risk of deep vein thrombosis or venous thromboembolism, it's exactly the same story, that when you combine estrogen with synthetic progesterones, you see increased risk of blood clotting, but not when you combine estrogen with natural progesterone. Same story, same outcome. Let's talk about androgens a little bit, because they're often overlooked, often not replaced in women, but look at some of the benefits. They affect bone mass, they increase muscle mass, improve well-being and mood, improve sexual function, help to maintain pelvic health, and improve insulin sensitivity. And also, interestingly enough, known to oppose the estradiol stimulation or estradiol-induced breast stimulation and reduce risk of breast cancer. Often people talk about testosterone as a risk because of the fact that it can convert to estrogen, and therefore it represents an increased risk of breast cancer. The studies do not show that and do not confirm that. And here's a summary. This is as long ago as 2009. Look at the conclusion. The predominant data shows that low-dose testosterone use is safe in regards to breast and endometrium, with experimental data suggesting a decrease in estrogen-induced breast epithelial proliferation. No adverse cardiovascular effects. This is really important. Now then, in the last bit of this talk, and I did warn you it was going to be a sort of whistle-stop tour, I'm just pointing out on this slide the sort of precursor hormones, pregnenolone and DHEA. Very often overlooked, very often not restored in conventional circles, but they also have impact on our physiology, and I'd like to walk you through some of that. This slide is really to show you that DHEA, pregnenolone are up at the top there, and I refer to them often as parental hormones or precursor hormones. So DHEA falls as we age. I showed you earlier on, even from the 30s, DHEA is one of the hormones to fall first. In fact, DHA is the most produced hormone in the body. And look at some of the benefits. It boosts well-being, It's effective against stress. It improves sleep. It improves powers of recollection, strengthens the immune system, improves lean mass, decreases fat tissue, improves insulin resistance, improves sexual satisfaction, increases bone formation. We noted that earlier. And increased vaginal epithelium with no endometrial effect. So you can use DHEA intravaginally as an alternative to using estrogens to restore the vaginal epithelium, and that is something that I often do. And what about pregnenolone? Well, let's look at this summary. So regulates the balance between excitation and inhibition in the nervous system, increases resistance to stress like DHEA did, improves energy both physically and mentally, enhances nerve transmission and memory, reduces pain and inflammation because it's a natural anti-inflammatory, blocks the production of acid-forming compounds, helps to repair nerve damage, promotes mood elevation, improves sleep, enhances acetylcholine transmission, increases learning, memory, and alertness. Pregnenolone, often referred to as a brain neurosteroid, because often, in fact, one of its common mechanisms is that it improves brain function, also anti-inflammatory. A word about maybe topical hormones, because this is an area which is often overlooked. If you look at women who have their hormones replaced compared to those who are non-treated, there's definitely an increase in the collagen content of skin in those who receive hormones. The good news is that you can recreate this effect topically, and that was the reason by my creation of this range of Biogen creams which contain low dose of bioidentical hormones. And this is data which shows that when you use different hormones, progesterone, estriol here, you can improve the elasticity of the skin, building collagen by using them topically, not just systemically. It's very exciting. A skip through vitamin D. I know most of you will probably know this now, but I wrote this summary paper, Vitamin D, an underestimated ally. It's been very topical and relevant in the whole last 3 years when we've been talking about COVID. There's no question that the data that's coming out now shows that those people who have even normal levels of vitamin D are highly likely to have only low impact of COVID or no symptoms at all, let alone if you have optimal levels of vitamin D. So the data is overwhelming and shows that now, but this is should have been headline news in press, has not been, as most of you will know. This slide was published 2016, or at least this paper was. This is a slide from it, which shows that when you get above 50 nanomoles of vitamin D, I beg your pardon, when you get above 50 nanograms, which is equivalent to about 100 nanomoles per liter, then you see a sharp drop-off in the incidence of cancers. And that's all cancers, it's not just breast. So there is something about having levels of vitamin D at a certain level, i.e. above 100 in my book, and this paper shows that seems to be protective against cancers. Well, this is one of the big things that I advise women, men and women in my practice, get your levels above 100, because not only is this important to immunity, bone mineral density, but it's going to give you a level of protection against cancers in the long term. And these are studies which show for breast cancer, women with low levels of vitamin D in their breast tissue have 4.5 times the risk of breast cancer. And here's another study from Creighton University. Those who took just 1,100 units, which I think is still low dose, with calcium over a 4-year period, they observed a 75% reduction in breast cancer diagnosed after the first 12 months compared with women who took placebo. That's quite dramatic. 75% reduction. Melatonin, the last bit I want to talk about now is melatonin. Again, I've got to skip over this, but I did write a paper, Melatonin, a Universal Guardian, based on some of the data or some of the facts about that from the scientific data. And here, this just shows if you give, this is quite remarkable, if you give aging mice melatonin in their drinking water, they start to look like and behave like younger mice. So these mice are the same age. This is untreated, but the one on the left has received melatonin. Look at the difference in the coat, and actually the behavior is different as well. So we know that melatonin has some anti-aging properties. And also, if you look at this slide, we know that melatonin gives you protection against breast cancer risk as well, because here we see it going up in menopause. Those women who have higher levels of melatonin have reduced risk of breast cancer. That's extremely important to know that. And this is one of the ways that we can reduce risk. So I just put this slide in as, I think it's the penultimate slide, just to show you some of the things that I test if I want to look at aging and how I can make an impact. So I do look at sex hormones. I also look at adrenal hormones, vitamin D, of course. CYP score is the omega panel, so we're looking at the omega fatty acids. Pulse, many of you may not know, is basically a blood test which looks at inflammatory markers in the vascular tree. So this is a very significant test because it's an early warning of vascular changes, much more relevant and much more significant than just looking at cholesterol and things like CRP. So this measures markers of vascular inflammation. And then I look at general inflammatory markers, and the other thing is heart rate variability. That gives you a clue as to how well the autonomic nervous system is working. And if you didn't know, that goes out of balance as we get older as well. So that often is a useful test of how the system is faring. So in summary, there are natural ways to slow aging. I only talked about hormones in this presentation. Hormones, in fact, are often ignored. If they are used, they should be given in the safest form, which is, of course, body identical or bioidentical, so BHRT. Natural hormones have many anti-aging wellness benefits without long-term side effects if they're used correctly. And I think I've illustrated that in this presentation. And then the last thing is facial rejuvenation can be achieved naturally without toxins or surgery by the use of low-dose, topically applied bioidentical hormones. So I'm going to leave it there for this time. I hope you found that useful. For those of you who want to get in touch for any reason, this is my main contact. I'll leave you with that. God bless you all.